Welcome to the InFocus session, Humanitarian Service and Rotary Foundation working together. Each month we look at a different area of focus and bring you inspirational speakers to give you ideas for your clubs and districts as how you can put the things into action, real Rotary in action. Every session is recorded and you can find them on YouTube. In fact, there's a library of the InFocus sessions from this Rotary year and last Rotary year. They do make good extra things for your club to look at meetings if you wish. This evening, we're looking at maternal and child health, a very important area for us all. And our speaker, we are so very, very fortunate to have. And during his talk, please feel free to put questions in the Q&A, and we will do our very best at the end to get them answered for you. So the maternal and child health speaker for this evening is Dr. Himansu Basu. He is an absolute expert in the field, and Himansu is passionate about the elimination of unnecessary deaths during pregnancy, at birth, and the deaths of babies in their early years. We are very fortunate because he is in fact the medical director for the Rotary Action Group for Mother and Child Health. So it is with immense pleasure that I would like to invite Dr. Himansu Basu to speak to you this evening. Himansu.
Just unmute, Himansu.
Dear Rotary friends and friends of Rotary, good evening, good afternoon, and good morning. Thank you, Cheryl Berry, for your very kind words and introduction. Please allow me to go back 7 years and thank Rotary GBI for bestowing the Rotary Champion of Change Award on me in 2016. This is my first opportunity to thank you, leaders of Rotary GBI, publicly on behalf of our CalMed team and I. It is known that we Rotarians are celebrating Maternal and Child Health Month of April. This evening, we wish our presentation to be dedicated to the most important person in our lives, our own mother. She was our life support machine for 9 months. She brought us into this world, and in doing so, risked her own life. 800 mothers continue to make this ultimate sacrifice every day in countries around the globe. Please allow me to tell our story on behalf of a group of Rotarians, health professionals, and activists teamed around Rotary International District 1120, my own district, which has been providing support since 2010. I take this opportunity to acknowledge the enormous contribution made by District 1130. Michael Hodge is representing there. We did start together, and I expect they will be continuing with the work. We are working together to stop mothers and babies dying at childbirth. It is our story, happens to be also my story. So let me begin at the beginning. My early childhood in a remote part of India was happy. But tragedy struck when I was only 15 years old, still at school. My mother died a day after her 7th childbirth. I wasn't there, heard that she was hemorrhaging profusely. There was blood everywhere. She was waiting for an ambulance to take her to a hospital, and then she died. My whole world fell apart. I could not get an answer to my quest. why did my own mother, who loved me so much, have to die? I went to medical school, specialized in obstetrics and gynecology, then got engaged in hematological research, seeking relevant answers. I should add that collaboration is in my gene. I was fortunate to be able to join and be supported by a group of international research scientists when I was based in my own small lab in Liverpool in the 60s. It involved collaboration with scientists and laboratories in Oxford, Liverpool, New York, Minnesota, Toronto, Warsaw, and Oslo. Our work was, as I said, on elucidation of mechanism of hemorrhage around childbirth, why mothers die of hemorrhage. I'm humbled to say that our data paved the way for treatment of hemorrhage with a new drug, and that was 50 years ago. As a clinician, academic, lecturer, and examiner of the Royal Colleges for over the next 3 decades, I became aware of the global inequalities of health infrastructure. Childbirth deaths often resulted from fractured health systems in low-resource settings when major complications set in. I became also aware that we could actually stop mothers dying, even though initially did not know exactly how to or where to start. My exposure to Rotary Inter-Country Contact Committee, ICC, Rotary Foundation Future Vision Plan organization, and global networking groups changed all that. I became conversant with the good work of our Rotary Foundation, including as a vocational training team organizer, a cadre coordinator in maternal child health. During the last 2 decades, I felt that through collaboration and the Rotary Foundation support, we can leverage our professional technical expertise and expect to reduce preventable maternal and child mortality. It has now become an achievable goal as a part of doing good in the world, and importantly, at an affordable cost. So instead of asking why mothers die, the slogan has now become Stop Mothers Dying. I take this opportunity to thank everyone who continue to work with us to reduce avoidable maternal and newborn deaths in low and mid-resource settings, income countries. Some of them are here with us this evening. We all are ordinary Rotarians. Our story is about how ordinary Rotarians are doing some extraordinary things with support from our Rotary Foundation and our volunteer healthcare professional collaborators, VTT members and others, working in alignment with Rotary's vision, which is, together we see a world where people unite and take action to create lasting change across the globe in our communities and in ourselves. So my friend, it is our story, it is also my story, incorporating action by heart, head, and hands. Hope you can make this your story as well. So let me go on now to explain a little bit about CALMED. You will hear a lot about CALMED, collaborative action in lowering of maternity encounter deaths. So let me move on to slide 1. I can't share the screen slide. It says host disabled.
Try again, please.
That's fine. Thank you. So we start, as I said, in memory of mothers who sacrifice their lives in childbirth. It's a very sacrosanct issue, and I make no apologies for being a little emotional about that. I think it's very important. So we now move on to say why we are doing this on behalf of our mother, and the answer is mother is the most important person in our lives. Secondly, how we did it, this is us, Rotarians and others, and I'll explain this to you, unite in solidarity, in support of local efforts and which coalesce into global efforts. And obviously, it's a long story. So my friends, please look at our website, calm.rotary.org. There is also an RMCH, calm.org. And finally, may I say that I present this on behalf of participants, trainers, and supporters of Calm, a big team. So I am conscious that the time available is limited. So I'm going to mention just a few things, 5 different things, like the background first. Then I'm going to mention a solution, which is based on a strategy and evidence. Then going to describe field testing, what we did, where, and then describe where do we want to go, where we are looking. And finally, there's some key messages. Or in other words, it's about what, which, why, where, how. So let's have a look at the happy event, which happens all the time. And if you look at it, they are creating a new life. It's a very happy event. Generally, nothing goes wrong. Nobody even thinks about it. But do they know that they are also risking their own lives, that things, childbirth, especially in remote countries, low resource setting, is not an easy task. It's full of risks. Now, don't believe me? Let's have a look to see how does childbirth risk compare with other things. Here, these are evidence-based, by the way. The risks are described as 1 in. So remember, the higher the figure, the lower is the risk. Now look, if you climb up to the base of Mount Everest, it's 1 in 1,750. If you do scuba diving, it's 1 in 34,000. And if you do the sky jumping, I'm told it's 1 in 100,000. Even the dangerous motorcycle racing is 1 in 1,000. But look at the picture where these women are crossing actually a river, and the risk is about 1 in 190. It's far more than motorcycle racing. And of course, things like the ordinary risk is about 1 in 700. It's still more risky than motorcycle racing. So what is happening? Am I just talking, or are there real examples? Let's have a look. Now, if you look at the picture, this is the tale of the unexpected. And it is happening. This particular one was in Assam and in 2021. They are carrying this woman literally through unmade road, and now this little road is made, no cars. And it is this delay in getting resuscitation to the right place that's causing the problem. And as I have explained to you, 800 mothers are dying. Now, it's not the 800 mothers. With them, 6 times as many, 6,000 babies are dying. And with them, another 5 times, 4,000 mothers are damaged. So it's, although I keep talking for the rest of the talk, the 800 mothers, please remember, there is damage and death of the babies as well. And the sad part of it is, these are mostly preventable. And they mostly occur in South America, South Asia, and Sub-Saharan Africa. And I just quote somebody, Mamdou Fatala, he was the president of World Federation. He said in 1999, women are not dying, not because of the diseases we cannot treat. They are dying because the societies are yet to decide that their lives are worth saving. Just think of that. So it can be prevented. If these women were in Milan, London, or San Francisco, they would have been saved. So that is our challenge, my friends. So let's have a look. See, this is the local problem. Let's see what's happening worldwide. Now, this is a map. It's a bit complicated, but I'll just simplify it. It's a it shows what I call north-south divide. If you look at the green areas, their maternal mortality rates are less than what is called 100 per 1,000. But if you look at the red area, they're more than 500 per 100,000. So there is a big difference. And what I'm saying, and if I show you the areas, this particular issue here, the green zone have got more doctors, and the red zones and the orange zones have got less doctor and more death. So one idea would be, why can't the doctors swap places with the patients and they'll be all right? Well, of course, you know as well as I do that that's not possible. So we need, therefore, a strategy where somehow we need to reduce this disparity. How do we do that? Let's look at this. So we need to take action. We are Rotarians, we are people of action, and we do not say no for an answer. We need to do action which is based on strategy, because I think, my friends, strategy without action is just a dream, and action with a strategy is a failure. And this is exactly what we have done, and our story, in the next minutes, will explain to you what strategy we employed, what action we employed, which are based on evidence. Now, before we do that, this selective strategic action is what we need. This is a complicated slide as well. Let me just explain this. This is a sort of, imagine the woman's whole life, starting from adolescent. So the yellow circle, outer circle, represents the woman's adolescent and adult lifehood. You can do certain things. For instance, you can improve education, you can improve anemia, reduce the number of pregnancies, unmet need of contraception, improve the medical disorders like diabetes, etc. So you can do that. Then comes internally the blue circle, which is the 9 months of pregnancy. Well, you can do a good antenatal care, again, look after the women more important health. If things go wrong, you treat that. And then comes the red area, which is the sort of 48 hours around childbirth. Here, you've got to do something because things are too late. When problems occur, you've got to do something. And I'll show you in my next slide how a combination of problem is the one that's causing death. If the problems occur in just one setting, our body can deal with it. So let's see what these are. Now, the left side, it shows the main causes of hemorrhage. My apologies, but I'll just tell you main causes of death, that is. It's hemorrhage and raised blood pressure and infection are the three more important causes. There are many others. Please don't worry about that. So if we can treat that, the woman would be all right. This is during delivery. But, as I said, if you are in Milan, New York, Toronto, you will have treatment, you will have access. But if you're not, it causes delay. And delays in accessing and starting treatment make these treatable conditions untreatable. And this is, we describe as golden hour concept. So it's very important the clock starts ticking when any of these things happen and you go to act. Now, the situation is a bit like fire. Those of you who can see this, you will remember that in 2017, the big tower block in London fell down in about 2.5 hours in fire. I'd like to suggest that when emergencies occur, it's like fire. You've got to douse the fire, you've got to treat it, and not just wait for the ambulance. So let's expand this a little bit more and see what happens when these problems like hemorrhage, infection, obstructed labor, and other problems arise. And this is what I'm just summarizing, why mothers die at childbirth in poorer countries. Please remember, it has to be delay and these problems or fractured health system. So I picked up 3 issues. These are called medical and public health issues. One is obviously the health system isn't good. And secondly, there's 3 delays, and I'm going to explain that. That's what CALM program is based on. And thirdly, large birth rate. So the woman is having too many children, you need more beds, but women's body is also suffering. So what can we do to look at reduction of 3 delays from home to hospital? Imagine some problem, emergencies arrive at home, and then what happens when they go to hospital? So let's look at this. So in the middle is this maternal death burden. Now the first delay, when problems occur, the woman is at home, so people don't know what to do, they don't take it seriously, they don't think it's a fire, and there's a delay. Then having decided that she should go to hospital, then there's a second delay. You try and get an ambulance, and you try and see if there is a transport available, the roads are bad, so that's the second delay. And then even when you go to hospital, they say, oops, the doctor is not on call, is not there, and they can't deal with this, so there is another delay, you go to another hospital, or you probably die. So this is the 3 delay, and our program is based on countering the effects of these 3 delays. So what do we do? This is called collaborative action in lowering of maternity encounter deaths. Right. Now, so I just want to highlight that it is a template of action. It's not a rigid action. It's based on what the problems are, what the solutions are, adaptable to the needs and priorities, basically to enhance the impact of global grants. Let me just explain this a little bit to you. Now, say you go on holiday in somewhere in Africa, and they come and say, oh, look, doc, a lot of people are dying. Can you do something? You go, and then the hospital says, can you buy us a machine, ultrasound machine? You collect money, you do that. Trust me, my friends, in many instances, you go back 3 years' time, the machine is not being used, they have got many other problems. So you've got to look at what the real problems are, have a good needs analysis and community needs before you do any global grant or give any money. This is the one message I want to very strongly emphasize. So we need a template of action. We need to find out what they need, and then we educate people. This is particularly the medical professionals. So if you have, say, 10 doctors, we are creating an outer layer of another 30 or 40 people. They're not doctors, but they will be able to give you first aid, maybe 8 or 10 chance that somebody will survive. Similarly, we empower the local community. They need to be aware of the program. And thirdly, we evaluate. So I call it a good value for money. So the Rotary Foundation Global Grants, not only doing good in the world, but doing more good in the world. So let's remember that our objective is to enhance the global grants, and it has these 3 strategies, and it must be tailored to the needs and output, and we must measure the impact and ensure sustainability. So let's move on to see how this is done. Now, we used a vocational training team, and we use a training the trainer model. So that's quite simple. This is the basic structure. So you send, say, 5 or 6 very experienced obstetricians and so on from, for instance, England or USA to a recipient country. They then train about another 10, 15, 20, 30 somethings in basic resuscitation and emergency treatment. You use simulators, you use films. It's a bit like pilot training, sitting still, and you particularly allow the poor learners to learn. And we use, the objective is to improve their knowledge, skills, and confidence, so that confident leaders will create confident practitioners. Now, this is a group, we did it in Bhuj, in Gujarat, in one of these. But let's look at a little more detail as to what it involves. Now, apologies, this is a slightly complicated slide, but I'll explain. Please don't worry. This is the basic thing I repeated, training the trainers. So we train And then first week and then second week, they train the lower level people who come in, and we simply observe and make them confident train leaders and confident trainers. They are the heroes. Now, the first delay to reduce, we need to go to the villages, have a bottom-up approach. We need to teach them how to eat during pregnancy, what are the danger signs, or where to seek for help, etc. And this is the women's groups. And there is data showing that the reduction of mortality is up to 23%, a quarter. Second delay is more difficult. There are no ambulance, no roads, but I'm aware that in many parts of the world, there are motorcycle ambulances, just a sidecar, and it reduces the delay. But also, we need to resuscitate the mother and the baby. It's no point just putting them on a motorbike and send them in journey for 10 miles, which takes 2 hours. You need to start your resuscitation. And if you're interested, we can discuss that at question time. The third delay, this is the most important thing, as I've explained. This is the training the trainer model, but then they also learn within hospital, in situ, there is a skilled professional enhancement. And this is the best one. It reduces mortality by about 39–40%. This is what we want to do. So let's move on to see how this peer-to-peer in situ simulation, how do we improve the practice of the maternity care? Because lecturing is not the idea is to improve practice. Now, this is the other half. This is where the villages, so we get a group of nurse tutors, and they use the pictorial flip charts, very basic. There are additions to that, and I'll explain that to you later. And they are teaching what I call ASHAs, accredited social health activists, and they then go to the villages, and you've seen a picture earlier on, and they teach, they improve the health-seeking behavior. Health-seeking behavior is improved. Now, let's look at the other part of the training, and I explained to you, training the trainers. This is a picture showing how to insert an intrauterine contraceptive device. It's called the simulated training, but there are other devices, like this is called Mama U, by the way. There are other devices called Mama Natalie, Neonatally, Baby Natalie, so we can train how to resuscitate mother, baby, and how to do other things. The basic idea is training the trainers, but that involves skills training using simulators. We use role play as well. It involves self-training. You know, they go and look at videos, apps, manuals. So there's a lot of self-training as well. And guess what? It doesn't stop there. They do peer-to-peer training, the chat. The stronger trainee teaches the weaker trainee, I suspect. And then they do what is called a collaborative learning protocol. The whole group at intervals get questions and their progress is monitored. And finally, and this is something new, we like to do that, like mentoring and telemedicine. So whenever the global grant is finished, the relationship persists, and we want to help them to be more confident trainers. So it's the pillars on which this model is based is absolutely sound, and I think I'll explain to you later how this is being taken forward to this current state. Now, I know what you're thinking. You're thinking, that's all very well. You told us all these things, but what about, it's a big task. Right, well, we have to therefore do something to add strength. And we do what is called collaboration. I haven't got time to explain all this, but each of these logos represent a company. This is World Federation of Obstetrics and Gynecology. Lardal gave us, this is the simulator manufacturer. They gave us 3 for the price of 1. Gloom gave us free of charge. And this is the government, by the way. And this is my action group. Medical Ed Films gave us things free of charge. So we get a lot of materials through external partnership. They do help, and without that, we would not be able to do what we have done. So let's move on to where we have actually done. Now, the action and the outcome that we have done, I'm going to summarize. We have completed 2 global grants And Michael's grant isn't included in this, by the way, so he has his data. We did 3 preliminary visits to find out what they need, and we modified our program accordingly. This was followed by 6 BTT visits. Our lead district is us, preparatory work, and then we've done training, retraining, mentoring, and data collection in 2 places, Northwest India and Northeast India. So what happens? Who are the heroes? And these are just the pictures of one group of VTT members. The initial treatment team is quite large, 6 to 8, but the second and third visit smaller, 3 to 4. And this is the one, another team in Bhuj. Now let's look at what we achieved, but that's all that matters. Did we make a difference? The answer is, yes, we did. And what happened, this is the basic facts. These are our 6 BTTs, covering a period of 44 weeks. And then we trained 39 master trainers. As I explained to you, they are the heroes. They trained something like, sorry, I'll tell you that later. They trained something like 218. Our target was 200 basic trainees. And then the ushers were trained. Our goal was 500. Again, it exceeded. Now, the question is, how many mothers' lives we saved? Well, in India, those of you who are familiar will know that the maternal mortality is not recorded very well outside. So they do what is called a sample registration survey. It's a sort of modeled estimate. And our estimate is we saved 250 mothers' lives and about 1,250 newborn babies' lives. Now, we therefore conclude, I'll mention this in a minute. We therefore conclude that the CALM program and associated initiative was a low-cost, effective program. Only $400 of Rotary Foundation money was associated with saving 1 mother, 5 babies, and resulted in effective training of at least 1 extra doctor or nurse in the care of pregnant women in the target area. I think that's something quite achievable, we should follow that scheme. We did knowledge score, skill score, and behavior change. They all improved. And the next slide shows how the score system works. It's slightly
5 more
complicated.
minutes, Himansu, please.
Well, I'll have to hurry up. The scores were improved on both of these. Then program didn't finish there. We had our situation where we resulted in a toolkit. We have all these available free of charge. We have partnership. We don't have available with Foxy and others. We have task force, which is repeated training master trainers, these guys. And finally, we have the maternal perinatal death surveillance measurement. So all these resulted in materials which are freely available. And I'll show you in the next few slides how we are going to promote that. Next one is where we are. This is where we are in Northeast again, where the mortality, the COVID produced some more challenges. So we are doing another global grant. We have a population of 1.86. But what I'd like to show you, we're producing distance learning material, we're using apps, digital technology, and of course we're going to the hospital. It's easier. But there is one thing we didn't do very well in the other 2, which is to treat and explain MERN, Maternity Emergency Response Network. So we're just going to do that, how we can help. Here is the management or the situation. Imagine a woman is bleeding, so she gets an app. She triggers the call. The ambulance station is notified. They come and they actually start resuscitation at that level. Hospital is notified. So it's a hub and spoke concept connecting the hospital to the mother and child. So it is basically the treatment is in mother's palm. Now I'm going to move forward because of the lack of time. I'm going to, please bear with me. It's what I'm describing now is what we're doing now, looking to the future. We are daring now to go to the global stage. SDG stands for Sustainable Development Goal Goal 3 shows the maternal mortality ratio should be 70 or less. 10 shows that it should be equitable coverage. 17 shows that we work together. So all these tick the boxes and we're preparing to go forward. How? This is the thing. We're starting an initiative called Techno. I'm happy to report that this is coming from the Rotary Action Group on Maternal Child Health. 3 levels of cooperation are joined together to bridge gaps in care. One is the country-level cooperation with a women-centered approach. This is a bit like CALMED. We have got government, NGOs, Rotary, and there's a north-south cooperation, top-down and bottom-up approach. But we are creating a tactical hub. Remember, we have got these technical experts, we've got toolkit, so we can give advice to people, anybody who want to do a global program, global grant, and others, where to get it, how to get it, and even financial advice. And finally, we are building strategic partnership. The global organizations, they are helping us with the human resources, advice, and strategic leadership. So that's very important. How do we promote that? I've got to move a bit fast, but this is the country level and give examples. This is CALM we have already done. This is the improved health seeking behavior, we have done that. This is the women's group. High birth rate, I showed you the insertion of IUD. So let's move on to the next, which is the Techno Expert Hub. This is what is left there. So we can give people advice, we can give them materials. So Toolkit and Task Force are both very important initiatives if anybody wants to do similar programs, and we're giving them advice and support. And finally, we still have our Techno, RMCH, all these people are there to help. We have added by FIGO, JPIGO, so there is scope for everybody. So whole world is at our help, and because let us not underestimate the power of Rotary. We do have a lot of power action. So let's call for action. This is the most final few slides. I think we should imagine.
We're really running out of time here, Himansu. We have got questions.
Sorry, they might be able to ask questions. Just give me 2 minutes and I'll finish.
Thank you.
Yeah, thank you. This is the strategy we imagine, and this is our call for action. So the action is, can we, and this is to us, can we accelerate progress and create a Rotary GBI hub for Techno RMCH to stop mothers dying? And if you think that's too big, I think of Rotarians, we're uniting, think of the red areas, and we are in the green area. Can we not join together? That is the need of the hour. I think we should accelerate progress, and our experience shows that we can. And I just remind us, what can you do? If you're a health professional, you join us to the Rotary GBI Techno Hub if we decide to go ahead. If we are Rotarians inspired to act, do a program with the global grant, all the details will be here. You can write to us. And if you think that's a lot of work, well, that's our take-home message. 3 messages: that it is possible to reduce the death rate. CALM gives you one option. There are other options, but we can tell you how, where, when, because we have the resources available if you wish to act. So I think it's your decision. Please join us and we will work together. Now, if you think that's a lot of work, right. If Mother Teresa was here, what would she have said? She would have said, not all of us can do great things. We can do small things with great love to save mothers and babies' lives, to save the most important person in our lives. It's certainly, we have plenty of love in our hearts to do that. So I thank you for listening. If you have comments and questions, I'd be happy to answer. Thank you.
Thank you so much, Himansu. Absolutely inspiring. If we have had some questions from people who registered in when they put their registration in, they sent us some questions, and we've got an international audience with us listening to the inspiring things that you've been talking about. One is from Florida, and they're asking about solving specific maternal and child health problems, and if there are clubs that are actually wanting additional partners. So obviously you've mentioned that to an extent, but is there a specific way that they can link in? Because surely additional partners might mean additional money and certainly additional manpower to help.
I think, thank you. It's certainly is a very important question, and the one I'm delighted to be able to try to answer. The issue, remember, was between North-South divide. So I'm assuming from Florida, they are part of the North, and they want to do a program possibly in South America or South Asia or Sub-Saharan Africa. If that is the case, the best is to connect with Rotary. In that area, we have a Rotary Action Group, as you've heard. We might be able to put them in touch. We will do better than that. We can give them ideas to translate their situation analysis, their needs into action. Because as I said, there is no vaccine against maternal and child mortality. Each program has to be suited and tailor-made, if you like, bespoke program to suit the circumstances, to suit their needs and priorities and abilities. Money-wise, I'm aware that there are many programs like matchinggrants.org. Our action group would be able to help as well. So short answer is, keep in touch with us, look at our website, just chat to other people. It's chatting to other people that you find out what the needs are and who else is prepared to help you. Just to give you an example, sorry, may I just finish this? Our current program in Meghalaya, do you know what? The biggest donor was Japan, 2760. They have nothing to do with us. They gave $17,500 DDA. So it's all these are possible. You got to be chatty like me, I think.
It's all about the power of networks, isn't it? Whether it's through the Rotary Action Group or through Rotary or through other community organisations. What another person has asked, what are the biggest challenges that you think we face in implementing projects like CALMED? And, you know, are there any similar projects in the pipeline, or is all your time and energy devoted on this area in particular, this particular initiatives?
Well, let me assure you that our whole Rotary world is doing projects of varying degrees. And I don't think we should judge that unless we know the whole story. Because many projects you can implement if the circumstances are ideal. To give you an example, we're trying to do the motorbike ambulance. But if there are no roads, or if the ambulance workers are not there in number, they cannot be trained. So my suggestion would be that talk to people who have done this, coalesce our thoughts, our expertise, and see if the Rotary Foundation money can go further. So we'll do good in the world, but we do more good. The only caveat I have is if we do something, please record your outcome. We need good data so that others can follow you. Don't just do it. So if you are shopping, if you like, buy something wisely, but make sure that your food is good and it's used up properly.
And share the successes so that others can follow. Finally, before I hand over to Derek, who will take the questions that have come in during the evening, birthing boxes and the supply of them. And I think that happens across GB&I as well as areas that you're working in. Does that have an impact on mortality and morbidity?
Well, this is a very difficult question to answer, but it's a good question again. If I was a scientist, I'd have said, oh, very little evidence is available. Now, that doesn't mean that it doesn't work. The other issue is that the birthing kit varies tremendously. Some basic birthing kits just have got a cord clamp, scissors, and gauze swab and gel for the baby. And then there's a more elaborate birthing kit with the gloves and with the instruments and the drugs that stop bleeding, etc. I think overall, it's used widely. I think it's a good idea if it is an alternative to nothing. But obviously, one alternative would be a good one with a better outcome would be to go to the hospital or a facility or be delivered by a traditional birth attendant. So I'm not avoiding answering this issue. I'm just saying to you, it's a complex issue to look scientifically into this and say clearly is difficult, but obviously it's better than nothing. So if you have nothing better, by all means, but I think it is a good idea.
Thanks very much. I'll hand you over to Derek now.
Thank you.
Thank you, Janine. I hope I can be heard and seen. We have a few questions which we received tonight. I'm going to start with the first one because it's of interest to me as well. It comes from Angela Gorman. She says, Angela here, Himansu. Rotary has done so much on the polio campaign. Surely we can do the same for maternal mortality. But how? We know what is needed. Would you like to comment on that, please?
Thank you. I know Angela quite well and her good work. I have to be fair here and answer as a Rotarian, and I hope you will allow me. I think polio, as any Rotarian, and I'm a Rotarian, is our priority. Until that is eradicated, that is so. Any other 7 areas of focus is not a top priority. But what I can say is a compromise, which is that in many countries, there are already initiatives by government and NGOs. And to give you an example, World Health Organization joins with governments called Quality of Care Network. There are about 23 countries. There are another 54 joint working team countries. Why can't we, Rotarians in those countries, join together with Rotarians from the green countries, the whole of Europe, North America, and Australia, to do programs? And don't be frightened to do it on a small scale, because every little drop of water makes ocean.
Thank you for that answer. The next question I have, it is again from Angela, I imagine. We have a database of over 100 midwives who are willing to travel to deliver workshops. Could Rotary provide a central fund that we can apply to in order to fund more visits? Michael Hodge, you said that you would like to answer this question. Are you online?
Michael would be better answering that, I think. My brain doesn't work. Michael?
Well, okay. Obviously, I'm not touching the right buttons on there. The next question I'd like you to answer. We had a VTT project in District 1130 in the year 2012-13. It was linking with the Mumbai district to stop mothers and babies dying in childbirth, when Mike Hodge was foundation chair of Rotary in London and I was district governor. This was Eve Conway. What is your ultimate vision for Rotary's role in reducing maternal mortality globally?
Well, thank you. Well, first of all, I pay tribute to Michael Hodge and Eve. Maybe you didn't realize that we started it together. I did mention in my presentation, we actually did the preliminary visits, went up, so we provided a lot of training and so on. There are reasons why it became too big and we separated. Vision has to be everybody's vision. It's not my vision. And I think it has to be, as I hinted to you, in competition with the other priorities. Polio is our priority. But taking maternal and child health is also a priority because there are economic reasons. If you improve her life, she provides income, she looks after the child. So there are economic reasons as well as emotional ones that I have explained to you. I think the practical solution would be where the receiving districts in India, Sub-Saharan Africa, and anywhere else is requesting our help. I think we should try and do as much as we can. This is exactly what happened. The one that you mentioned, I actually did this presentation not in person through a PowerPoint, and there was a guy called P.T. Prabhakar. He was the RI director. And you know what? This was presented at Rotary International Assembly, where the two groups of district governors. So one way would be to put it to the incoming district governors from the receiving, from the well-to-do areas and the difficult areas to see if they could join together to do something similar. Does that make sense? Or am I sort of not clear? Please say so if I'm not clear and I'll explain, because this is an important question.
Right. Thank you very much indeed for that. If somebody on the call would like to come back if they don't understand it, I might have time to follow that question up. Another question is, can you say more about abortion as a cause of maternal deaths and the safety of current medical abortion procedures?
Right. This is a difficult area, not difficult for me as a doctor, and I'm going to answer as a doctor and then go on to describe it to you as a Rotarian. As a doctor, about between 10 and 13% of deaths occur in abortion. You saw the picture, and providing abortion, safe abortion, should replace illegal abortion. It's as simple as that. And nowadays, the technique has been simplified. In my life, I actually started doing very simple outpatient procedures, and that worked as well, and there is good data available. So that's me as a doctor. If you provide safe abortion as a support of contraception, because no matter what contraception you have, there is a failure, and then you support. There are other things. The difficulty arises, the other half of me as a Rotarian, it's a very emotional issue. As you remember, recently in the US, there are problems. And I think we sometimes get mixed up between that and we avoid. So I wish I knew the answer, but my suggestion would be, if it is allowed within the law of that particular country, just to save women's life, and we are talking of saving lives, we should go ahead and support them, especially where there's a self-administered drugs and safer procedures that are being evolved all the time. I think it's a bit like wearing a seat belt. You know, if you wear a seat belt, you save lives. If you do safe abortions to stop illegal abortions operating, isn't that a good thing? So I'm asking you a question, or the question has a question rather than giving an answer.
Okay, well, thank you for that, Himansu. If I can just take you back to the question which I thought that Michael Hodge was going to put to you. I'd like to put the question to you, and if you could answer that. This is about training in Sierra Leone. We have a database of over 100 midwives who are willing to travel to deliver workshops. Could Rotary provide a central fund that we can apply to in order to fund more visits? As you know, we provide misoprostol, I hope I've pronounced that correctly, and I learned today that in Liberia alone, we have saved 10,000 mothers. The numbers of 300,000 total deaths are not reducing.
I think the short answer is, well, Angela, first of all, thank you for all you do, and you have a great heart. My suggestions are two. One, divide your program into smaller bits. And secondly, enlarge your team. As you saw, we've got a large team. If you go to our website, you will see so many people are joining. In fact, in Rotary Action Group, through this Techno, and I hope in Rotary GBI will take this up to support someone like Angela. In fact, our work, I think there is a need. If we can coordinate, I think I'll be very interested to be part of that process and part of the success. We will work, and we should work to the end, until we achieve this. And if we have not achieved this, then that is not the end. We must move on.
Okay, well, thank you. That is all the questions that I have. There is 2 or 3 minutes if anybody has a burning question to put to you. But I think now it's time for me to thank you for your most interesting talk on mothers and maternal health. I've certainly learned a lot, which I was not familiar with at all. You know, for example, explaining how mothers die, the significance of hemorrhaging in childbirth, and the things that you're doing to counteract that and understand an environment which will help save mothers' lives. So I'd like to thank you very much indeed for giving up your time. It's so much appreciated. And I hope that the people on this call got as much out of it as I did, because that it would be a lot. So thank you very much indeed, Himansu.
We hope you will join us on the May the 10th for the next InFocus session. Our speaker this time coming will be looking at Rotary Youth Exchange. And in fact, it's Abbas Jodiawalia, who is the current Treasurer-elect for Youth Exchange in Rotary Great Britain and Ireland. He's going to speak from personal experience about the wonderful opportunities of Rotary Youth Exchange. Please come along again and invite others to join too. Thank you.